Our clinical consultation network. This is something we do every week at 1:30 p.m. Central Time, and generally speaking, we take a case, we kind of break it down, we try to do a little bit of clinical education, and really, try to provide something that can help everybody in our system, in an IDD system at all, wherever you may be. If you're a direct support professional, if you're an administrator, if you're a clinician, behavior analyst, occupational therapist, nurse, whomever you may be, that you can benefit from what we discuss on here on the Clinical Consultation Network. So I'm really glad. Our participation is growing substantially. We've had quite a number of people here the last few weeks, and so that's really great. I think that shows, gives us an indication of how much interest there is in clinical issues that we all face on a daily basis if we work in the IDD field. So it's really great to have everybody here. We'll get into our topic in just a moment. I do want to remind everybody once again about the TIMAD conference, which is coming up on August 22nd. It's going to be at the Willis Conference Center off of McGavick Pike here in Nashville. And that is going to be a great conference. We have Dr. Thane Dykstra coming from Illinois, who will be presenting our keynote speech. And then we also have several other presenters who will be talking a lot about the use of technology in supporting people with IDD. And as we've learned over the several weeks that we have been doing the last several weeks, as we've been doing the Clinical Consultation Network, we've seen that there is a lot of use of technology that's going on. It's starting to come out and to be used more and more in our systems. And so really want to encourage that. I think it's a way of helping people with intellectual disabilities to be more independent, taking care of themselves. Now, if everybody out there will put your phones on mute, that will help a lot and make it a lot easier for everyone to hear everything that's going on. So I also want to let everybody know that we are recording each of these sessions. We are now going to be able to post them, in fact have posted them on the DIDD website. I'm going to call Michelle Bagby onto the line here just now to tell us a little bit more about how you can get to those recordings if you happen to miss one of our presentations here on Tuesdays, that you're able to do that. Michelle, if you could come on and just explain to people how they can get to that information on the website.
Sure. So I have put the link to the recordings in the chat box, and I'm also going to share my screen really quickly to show you exactly where those are on the website. Of course, I can't maximize it because then I can't read anything. All right. Goodness. I've lost my own web browser. Okay.
There you go.
I get it eventually. All right. So the link that I sent out, and I believe I sent it out again last week as well, but the link that's in the chat box will take you to this page that gives you the information about the Clinical Consultation Network, how to join. So if you ever need that information, it's there. If you scroll down to where the recordings are, they're separated by discipline. So if you click on a discipline, any available recordings for that discipline will show up. There are a few that are audio only. So if anybody has issues accessing those, they can definitely let me know. But each week I will get those up as quickly as possible after the presentation. So they are here.
So we know from time to time people can't make it on Tuesdays, and so we wanted to make sure that whatever discussion we had was available to everyone out there. So make sure people know about the availability of these recordings. As I've said on numerous occasions, these discussions are valuable to anybody in the system, not just to people of a particular clinical discipline or even a clinician at all, but administrators, direct support professionals, parents, person supported even may benefit sometimes from some of the discussion. So I encourage you to encourage anybody that you know to be a participant in the Clinical Consultation Network. This is all part of building a strong system. When we have a clinical education process that we go through, when we do this on a regular basis, it's one of those things that strengthens systems, makes us more capable of responding to crises. In fact, I've grown to not really like the word crisis very much. I like to think more in terms of just difficult situations that we have to face from time to time and deal with. That's what we do as part of our professionalism, as part of the service that we offer ultimately, is to be prepared for those types of things. And the more you participate in this clinical consultation network, I think the more you'll be prepared. I'm so happy today. This is just a happy, happy day. I've got my lots of love coffee cup here today. It's got a llama on it, so the lots of love is spelled with 2 L's on there, just a double L, lots of love today. I'm so happy because our guest today is actually also my co-host, David Taylor, who has explored a case involving an individual who fell a couple of years ago, and unfortunately this individual died as a result of the fall. And David has done some investigation here and has actually been less interested in the actual cause of his death. That was blunt force trauma, a typical type of head injury that a person may have that would cause them to die in a fall. But he's actually kind of drilling down and going back to try to determine what were the key contributing factors to this fellow falling. So I'm very happy to have David Taylor on the line with us today to discuss this case. And David, before we launch into discussing the case, as is our custom, I'd like for you to give us a little bit of information about yourself and just tell us, how did you get into this field of intellectual disability?
Well, it's kind of an interesting story. But first, to start off, I've been a nurse for 34 years. I grew up in Alabama. I hope y'all won't hold that against me.
No, we won't hold that too much against you. But, in fact, we probably have some Alabama people on the phone, I'm sure. I'm sure there are some out there.
So working in the hospital a little bit, I decided I wanted to work in the operating room, so I looked around for a school for that, and as it turns out, the Army has a school for that, so I joined the Army and went in the military to become an operating room nurse. After I left the military, I moved to Knoxville and worked at Baptist Hospital of East Tennessee and did open heart surgery there for 15 years. And I came into this field just by sheer accident. My wife was a nurse also in surgery with us, and she developed lupus, and we had 3 kids that were getting close to middle school and high school age, and she was sick in bed and on chemotherapy, and decided I needed a job that I could be more available with instead of being on call 5 nights a week and every other weekend. And so I started looking for state jobs and just stumbled across the regional nursing job there in the East, and I was pleased that the East director gave me an opportunity for the job, and 14 years later, I'm now the director of nursing. So it has been a wonderful, wonderful field. It has been the best nursing job I've had, and it's things like this case today that make it so interesting, because you can learn things that might help a lot of people.
There are so many things with these cases, these complex cases that we discussed, that are just really allowing you to kind of dig in and really be a clinician to try to understand more about what's going on. And like you said, to help people. I think ultimately what's going to happen is that more people become aware of these things and maybe can intervene earlier and more effectively to try to help someone. So that's really great. I was your wife is also a nurse, so it's something that it's a family affair for you guys.
Oh yeah, it's just I knew I wanted to be a nurse when I was 15 years old. That's all I ever wanted to do.
I was so thankful when we recently had our horse experience out here at my property that you and your wife were here to help us with a little first aid scenario that we had, where some assistance was needed. So having the both of you here was really a great thing. So I really appreciate having you on today, and you've got this case that you want to discuss with us, and that I'm sure will be quite enlightening to people. Can you kind of give us a little bit of the thumbnail sketch of what this case is all about?
Sure. This is about a gentleman. He was 38 years old. He was nonverbal. He lived in an individual residence with level 6 funding, which is 2-to-1 staffing 24/7. So he had a lot of behavioral and mental health issues that warranted this type of level of staffing. So on the day this occurred, he had an unguarded fall from standing, and he impacted his head on the concrete floor that resulted in bleeding in the brain and a subdural hematoma, and he subsequently died. The autopsy listed the cause of death as blunt force trauma to the head, resulting in intracranial hemorrhage and a subdural hematoma, which was fairly obvious.
Yeah, so as we always know, David, in these cases, so yeah, I was just going to say, you're going to try to peel back the layers of the onion. The interesting thing is not that he fell and harmed himself. I mean, of course, that was a very tragic thing that occurred. But your goal, I think, is to pull back the layers of the onion and kind of tell us a little bit more about what you think may have contributed to him falling.
Well, as it turns out, there was multiple things that I think led to this fall. One of the first things that seemed so obvious to me was over-medication. And then as we looked into those medications more, we discovered there were drug-to-drug interactions that could have possibly caused an irregular heart rhythm that may have led to it, or some medications that may have caused hyperglycemia or diabetes. And then he had a history of seizures on top of that. But his diagnosis included impulsivity, agitation, psychotic disorder, GERD, tachycardia, autism, constipation, allergies, high blood pressure, schizoaffective disorder, OCD, epilepsy, pica, mood disorder, and intellectual disability. So it's a handful of stuff, and he, as a result, had a lot of medications. And some of the medications that the notable medications that stuck out to me were, he was taking Clonidine 3 times a day for anxiety. He was taking Seroquel, which is an atypical antipsychotic that can lead to hyperglycemia and diabetes. He was taking lithium and Ambien at night for sleep. He was taking Haldol, which is another atypical antipsychotic.
Actually, that was a typical antipsychotic, right?
Is it?
Yeah. So,
thank you, it is. Yes, I read my note wrong. But onward, he has also taken Paxil, Klonopin, Depakote, melatonin, Lopressor, and the biggest thing I noted about all these are medications that can be very sedating, and especially when you add them together. And
oh my gosh,
can increase.
I'm counting 1, 2, 3, 4, 5, 6, 7 medications that may well be considered psychotropic medications for him. So Depakote, I'm assuming, may have been. Did you say it was
seizures?
Control? Oh, seizures.
Seizures.
Seizures. Okay. Well, it often is one of the medications that's given for mood control as well as lithium. And then you've got Seroquel and Haldol, 2 antipsychotic medications. And then you've got Paxil as an antidepressant. And what was the Clonidine? What was the purpose listed for the Clonidine?
Oh, that was for anxiety.
Anxiety, okay. Mm-hmm. So that is a laundry list of medications that he is on.
And apparently he was very sedated after receiving these medications, specifically at the 7 p.m. time. This agency that served him gave medications at 7 a.m. and 7 p.m., where a lot of agencies give medications at 8 a.m. and 8 p.m. So he was getting some really sedative medicines fairly early in the evening, and the staff spoke about how he would walk around kind of in a daze, giving the general impression that he was very sedated by these medications. And certainly that seemed to me like the logical reason that he fell.
And do you know, David, if that had been going on for some time, or if that was a relatively recent occurrence that they had noted his change in?
Apparently that was fairly long term. That was the normal.
Because he had been on these medications, but he had been on these medications for an extended period of time, I think.
Correct. And he had a lot of medical visits. He had a neurologist and a psychologist and a PCP that routinely saw him. He was seen by the psychiatrist the day of the occurrence. And this problem had been noted as much as a year earlier by the neurologist who wrote the note that he felt like he was over-medicated and was concerned about the risk of falling. And so he had reduced some of his medications that the psychiatrist had prescribed, which is fairly unusual to see a physician change a dose of medication another doctor prescribes.
Right. Do you know anything about his psychological condition or his psychiatric condition that led to him being placed on these medications? Anything about his behavior at that point that prompted this?
Other than just the indication that he had a lot of aggressive behavioral occurrences. This is the reason he lived alone and had 2 staff put in 2 hours a day. So I was thinking this had to be the reason, but just to be thorough, I wanted to, since we're doing this as part of the investigation, I wanted to look into all his records and see if there was anything that could have stood out. The day when they transferred him to the local hospital before they sent him to a trauma center, there was some lab work done there. I had a urinalysis that showed ketones in his urine. He had his glucose was 226. Had a total protein of 6.1. And these things can indicate diabetes or hyperglycemia. Also, he had an EKG that noted a right bundle branch block, that's a rhythm block in the heart, and a prolonged QT interval, which can lead to irregular heartbeats that can cause fainting or even lead to sudden death.
Yeah. Hey, David, let me mention this real quick since you mentioned QT interval. And I would like to have you explain that term here in just a second, but it's a lengthening of this QT interval. And so there's a medication that probably some people, maybe a little bit older people on the phone, might remember called Mellaril some years ago, which became very well known for increasing that QT interval. So I'm going to let you explain that in just a second because you'll be able to do it better than I can. But that is a medication that actually was taken off. I don't guess it was taken off the market, but everybody that I know who was on it at that time was taken off of it after this point at which it was found to so reliably increase the QT interval regarding the person's heart rate. So can you explain a little bit more about what that means?
Well, I kept that kind of short just to keep from getting too detailed about things. But but it is a heart rhythm condition, like you said, that can cause put you at increased risk of irregular heartbeat or having like a premature ventricular contraction that can lead to palpitations and fainting and that type of thing. And you have those PVCs and they get more frequent, and then you can trigger a tachycardia or some type of death-producing arrhythmia in the heart from that, just having that incidence of a prolonged fatigue interval. So he has obviously had some things going on that weren't necessarily picked up on by everyone that was seeing him. And that was just a surprise to me. And some of the symptoms that were described in some of those visits over that previous year were symptoms of diabetes. And I just think it just got missed. Since he was nonverbal, I don't think he could really communicate how he was feeling, maybe how these medications were making him feel, or
neuropathy, maybe neuropathy in his feet or legs.
Right. The one that stuck out with me was the hyperglycemia, because that can lead to ketoacidosis. And the FDA has a black box warning for atypical antipsychotics due to the possibility of developing hyperglycemia and diabetes. And one of the recommendations is to monitor blood sugar and for signs of diabetes. And fortunately, there wasn't any record of an A1C in any of his prior medical records.
So this is a little bit of a naive question, but I'm going to just go ahead and ask it just so that people are kind of attuned. What kind of symptoms would you see? I mean, so I know you'd see an elevated level when a person has hyperglycemia, but what types of signs would a person show if they're experiencing?
High blood sugar itself is a symptom of diabetes or hyperglycemia, but if you have hyperglycemia that persists for several hours, you can lead to dehydration and other symptoms that can occur, like difficulty breathing, dizziness upon standing, weight loss, increased drowsiness, confusion. And then for symptoms of diabetes, I wrote them all down, but I have to try to think on the top of my head to list them off.
Well, you mentioned a couple of them that seem really relevant. Dehydration, dizziness on standing, those are a couple of them. And then neuropathy was also mentioned. So any of those may affect a person's stability, I would think.
Yeah, absolutely. And he had a history of falling. He had a couple of ER visits where he had a seizure, and they noted some abnormal lab work. His magnesium levels were off, and this also can have an effect on the rhythm of the heart. And his blood sugar was elevated during that visit, and then he had another visit where he had fallen and had a laceration that was being repaired, and I noticed his blood sugar was a little elevated on that visit also.
So he had had previous falls.
Yes. The staff reported that he would fall a lot of the times when he was trying to put his pants on or take them off. That seemed to be one of the biggest times that he would have a risk for falling.
Mm-hmm. So had he been identified as a person who was at risk, significant risk of falling?
It's interesting because they did body checks on him twice a day, and looking for injury or bruises. So yeah, obviously he has a history of either some self-injurious behavior, which I didn't really see that in any of the records, or risk for injury from falls and that type of thing. Let's see. Yeah, and then as we talked to the staff more, they said medication really made him sedated and made him unsteady when he was walking around. And so that was just kind of interesting it just seemed like everything pointed to that over medication. Then there was I mentioned it already, but a neurologist visit where he reduced some of those doses of medications, trying to address some of the dizziness and falling. And
does it say specifically there with what you have, what they reduced?
Yes, they do. I can list it.
I'm sure one of those was
I wrote it in my notes.
Because I'm sure he wanted to keep the Depakote on board too.
He decreased clonazepam by 2 milligrams and the dose of Haldol by 5 milligrams.
Okay. What was do you know what the original dose of the Haldol was?
Well, at the time of the incident, he was on 10 milligrams TID.
So it could have been on 15 per
Could have been.
Yeah.
Okay.
Do you know what time of day? What time of day was the fall? Was it at night?
It was at night.
It was at night, shortly after his meds?
No, I was several hours after it.
Several hours.
I think they gave medications about 7 o'clock, and I believe this occurred between 10 and 11. He had gone to bed, and at one point he was laying in bed, but the next thing the staff heard was they heard this loud thump in his room, and when they entered his room, the way his body was moving, they kind of suspected he was having a seizure. But I don't think it was a seizure. It seemed like, as I talked to the staff more about it, he didn't present with any symptoms that really occurred when he had previous seizures, and specifically he wasn't combative after the seizure. All the other times that he had seizures, he was combative afterwards. And also note that he had not had a seizure in a little over a year since he started the Depakote. So what I think the staff were seeing was a decorticate posturing, and that's an abnormal posturing in which a person is stiff with the arms bent, the fists clenched, and the legs straight. Arms bent in toward the body, fingers and wrists are bent and held on the chest. And a lot of times the reason for this is bleeding in the brain, and certainly a head injury can be the cause of this, and that is a very serious condition when it gets to that. One of the other things that I think that may have impacted this fault is the day of the events. Apparently he got up at 7 o'clock in the morning, they gave him his medications, did his body check, and he went back to bed. Then he got up at 8:30, and they fixed him something for lunch, but before he could actually sit down and eat it, they forgotten they had a 12:30 doctor's appointment, so they went out the door without him eating, and went to that doctor's appointment. Then after the appointment, they went by the agency office, and then they returned home, and when they got back home, he went back to bed. So he hadn't eaten anything all day, and he got up at 7 o'clock that night, and they gave him medications, did his body check again, they went out to rent some movies, came back home, and he indicated that he was hungry, so they put a pizza in the oven for him, but he went in his room and fell asleep before he ate. So it doesn't appear that he ate at all that day, but yet his blood sugar was 226 when they got him in the ER that night. So
you wouldn't have expected him to have that high a blood sugar.
Yeah, absolutely not.
The entire day.
Yeah. So, and one of the other things the house manager noted that was he had experienced a weight loss of about 40 pounds over the previous 15 months. And so, that can be a symptom in itself there.
He had a, say that again, he
He had about a 40-pound weight loss in the previous 15 months.
Well,
He didn't have any type of diabetes insipidus.
Yeah, well, that's the thing. I think he did, and I think it was just missed by everyone. All his physicians and any of the staff at the home just didn't pick up on these symptoms.
so David, I think to a lot of people it might come across as a little bit counterintuitive for him to have been losing that much weight and for you to suspect diabetes under that circumstance. Can you explain a little bit more about that?
Well, the weight loss can be a symptom with hyperglycemia. Typically, it's a little more rapid weight loss that you would see, but that's still kind of a weight loss that you might expect if you're having hyperglycemia.
Okay, so that is, am I correct to say that it could also be weight gain that a person would have at that time?
It could, yes.
Yeah. Could have either effect.
But with this, it's more of the rapid weight loss and with dehydration and with all the medications he was on. You know what?
He actually was dehydrated in the fact that he probably didn't drink a whole lot.
Right. Do you know what time of year it was? What season?
It was June.
We had one that had a person that had a stroke from that. So the same thing kind of happened to him.
Who is this speaking now?
Mrs. Mary Brinkley from West.
Yeah, thank you, Mary, for that contribution. Yeah, I think it seems like there were so many risk factors going on here that there are a lot of hypotheses about what may have happened. But I do think I hear what David's saying. He was experiencing dehydration, perhaps dizziness on standing, and other things associated with hyperglycemia, potentially leading to this problem. Now, David, as you think back on this case, like one of my questions, I guess, is what types of interventions? So say we had been noticing this to the degree we needed to. I mean, I applaud the neurologist's effort to try to reduce some of the medications he thought might be contributing to this. But what kinds of things might you have thought about as interventions to try to prevent this from resulting in an increased risk of falls for him?
Gosh, that's hard to think about because I look at the situation and I look at what was going on with the person and was there anything that really stood out for the staff? And I think that so much of this just seemed normal for him because of the medications that he was taking, and it did cause some possibly dizziness and some falling and steady gait. This kind of thing that everybody just kind of wrote it off as a side effect to the meds, and
it became sort of everybody's baseline impression of him.
Yes,
he was a fall. He's just a guy who falls a lot.
And David, this is Ken Gibson. I got a question also.
Was there a what?
Was there a nurse with this agency, or was staff basically?
There was, but not with this person, and so the nurse at the agency wouldn't necessarily have reviewed this. But as I looked at his medications, I wanted to, if anybody doesn't know about it, drugs.com has a very good drug interaction checker that you can use. And you can just go to drugs.com and look for interaction checker and find it and enter in all the drugs that a person may be on and see what kind of drug-to-drug interactions there may be, or they also list food interactions with those that you can look at. And sometimes that can be very useful when you're trying to figure out what's going on with somebody. But
what was that website again, David?
It is www.drugs.com. You just look for their interaction checker. All right. as I entered all his meds into that checker, and it came up with one major drug interaction that increases the risk of abnormal heart rhythms, one drug interaction that increased the risk of serotonin system, one major drug interaction, another major drug interaction increased the risk of irregular heart rhythm. And then the moderate drug interactions that can cause increased side effects such as dizziness, drowsiness, and difficulty concentrating and that type of thing. So he definitely had a lot of medications that were sedating.
Yeah. Were there particular drug interactions in that group?
Haldol and lithium can affect the rhythm of the heart. Haldol and Seroquel and Haldol and Seroquel increases the risk of an irregular heart rhythm. And those were the two main ones that I picked up on.
Well, and
I have all listed.
In a couple of those cases, especially Haldol and Seroquel, you have two medications there that are addressing pretty much the same issue, which is psychosis. So he had a diagnosis. He had several psychotic diagnoses that he listed. I assume you're reading from the ISP, perhaps, where every diagnosis in the book is pretty much listed.
Correct.
Every diagnosis that was ever given for the person. I heard schizoaffective disorder. I think I heard psychotic disorder, not otherwise specified, and maybe one other schizoid type diagnosis that was on there. And so as a result of that, he's on Haldol and Seroquel. So in some sense, that's double duty there. That's two medications addressing the psychotic issue. You know, that for me seems to be one of those red flags you would start looking at with this, and to find out that those two are actually, you know, that there's a drug interaction between those two. I'm assuming that's probably just heavy sedation under that circumstance. That certainly could have been a big contributing factor.
Well, the irregular heart rhythm thing stuck out to me, especially that EKG indicated that he had abdominal branch block, T-wave abnormality, prolonged QT level.
That irregular heart rhythm, would you expect that might have been also a potential contributing factor to falling?
Certainly could have.
Okay.
Could have
Did
led
he have a cardiologist, David, that was looking at it? Because Haldol is definitely a high alert with someone who has a prolonged QT.
No, I didn't see any the cardiologist. The only cardiac diagnosis they had listed was tachycardia.
This is Stephen Bell, and this almost begs the question to ask, if all of the psychiatric medications that he was being prescribed were being prescribed by one person, because it sounds as if this is a situation that it's ripe for multiple prescribers who are perhaps not, there's no central court of review, so to speak, as far as his medications are concerned. So some of these interactions could have been prevented if one person were actually monitoring all of them.
Yeah, I think the neurologist was trying to do that at one point, because he was reviewing those medications, and he had tried to contact the psychiatrist and had not been able to get a hold of him at that particular time. But yeah, that just stuck out like that. It was a significant issue.
That's a big thing in this too, David. You know, so as you start peeling the onion back further on this, the divided care ends up being a bit of a concern as well, because as Stephen is pointing out here, that, you know, when you have several different hands in there, it's sort of like, we're not communicating, and it's easy to say, well, it's someone else's responsibility. Someone else needs to address this, and I think that is one of the things that causes people to get on these medication regimes that are just way out of whack. Because, and I'm sure we're not getting a lot of information about what his condition was that led to him being placed on these medications, and I don't want to understate that. I'm sure that there had been some benefit risk analysis conducted, to determine that, well, even though we may be taking some risks, that at least from the perspective of the clinician involved, that those risks were worth the potential benefits. The question, though, at some point, this becomes a circumstance where there's a law of diminishing returns. And, so our regional psychopharmacology review teams review anybody who is on 4 or more psychotropic medications. This gentleman was on 7, at least 6. If you want to count Depakote, which I think I would count from that perspective, is on 7 psychotropic medications. Then, that's, first of all, I don't know if you're getting the effect that you're desiring from those. I'm quite sure that you have some things on board there that are not really addressing the psychotic issue that led to, him getting on all these medications. But also, you're getting a law of diminishing returns where this is actually starting to cause them problems and significant problems. And so, I think sometimes it's hard for people to accept that there is a point where it's as good as it gets, or at least if I'm going to add something new, I need to take something away at some point to kind of counterbalance that. And to really be looking carefully at whether these new medications that are added are actually effective in addressing the issues. Because when you get this piling on effect, the very type of condition that you're talking about has the potential to exist, and that a person becomes very sedated, perhaps affects their heart rhythms to a degree that it makes it difficult for them to stand or to exert themselves at all, makes it difficult for them to, and may contribute to a metabolic syndrome of some kind that would create some of the diabetic problems that you're referring to. And so you get a whole complex of factors that are coming together to create a actually very dangerous situation for this man.
And that was really the whole point. I mean, there at the end, I started looking at this, and so we have documented symptoms associated with over-medication, like excessive sleepiness and grogginess, sedation, unsteady ambulation, and fall. And we have some symptoms of diabetes with the elevated glucose level, the decreased total protein, and the ketones in the urine. Then we have abnormal EKGs and irregular heart rhythm. So it's hard to pin it on one particular thing, but I think in this case, he may have just experienced an episode of ketoacidosis and may have just passed out because he fell face forward. He fractured his nose when he hit the concrete also, and just that unguarded fall. All these things seem to contribute to the reasons he fell, even though it's really kind of hard at this point to determine what was the real reason.
And this would not be the first time I've seen this where lethargy became sort of a baseline evaluation of someone. Just basically lethargy is just part of who they are. And there could be circumstances where that is just an organic condition that a person has, but where that is medication induced, I think until that's resolved, I don't know, you can correct me if you have a different idea on this, but until that's resolved, you really ought to continue working at trying to adjust until you can get the person to the point that they're experiencing whatever effects that you want to have from this medication, but also continuing to try to minimize that adverse side effect of lethargy that they may be experiencing.
And I'm wondering how much of these symptoms were actually communicated to the psychiatrist that was prescribing the majority of these psychotropic medications.
Yeah, I think
the office notes that I got for the previous year for that were pretty sparse. Fairly short notes from the visits, you know.
I've had a tendency, I probably in my own career had a little bit of a tendency to get accustomed to people who, particularly people who are on seizure medications, a lot of times having some sedation, you know, and maybe even some mild depression as a result of the seizure medications that they're on, and oftentimes you do have to have polypharmacy to address the seizure problems, and so as a result of that, you know, you'll see a person who's kind of, you know, just kind of not very with it, not very into it. But I think this case just really underscores the need to continue trying to address those matters with people, and not to just rest on their laurels, because we did see
some oversight by others.
Right.
Another eye on the person may have helped identify some of these things. But
I also think that what I've seen many times in Bruce, it hits to the lethargy becomes the norm, because you have a person who's a level of need 6 and there's no behaviors. So a lot of times you look at, well, he's not having behaviors, but not realizing the consequences that it's taking on the medical aspect of him.
Right.
You know, he's quiet, you know, we don't have to worry about him being aggressive, and too often all the medical side is overlooked.
Yeah. Oh, I agree. And as I said, I don't want to minimize whatever was going on, you know, prior to this. And in fact, I think knowing this individual somewhat, that he did have pretty significant symptoms of psychiatric symptoms prior to that. I don't want to go further with that because I don't know the case that well, but it was, you know, a circumstance where I'm sure there was a reason that people were trying to optimize his psychiatric care, but yet at the same time, you've got to continue to balance that with his physical health. And I don't think it's worth it to sacrifice physical health to the point that a person is sedated all of the time to address a psychiatric issue.
And for him being nonverbal, he really didn't have an effective way to communicate.
Right.
Anything that he was feeling to, even some, you know, someone else may have been able to say, you know, I'm tired all the time. These medications really make me feel terrible and this kind of thing. But I didn't get that impression from him that he was able to contribute to that.
He would be able to express that. Well, I'm just going to open it up to see if anybody else out on the line. We had a couple of nurses kind of jump in here. Anybody else out there, nurse or otherwise, want to ask a question or provide a comment?
I think it's a good time to stress the importance of staff communication with each of the prescribers, making sure that every prescriber knows every med that he's on, and not just assuming that the doctors are talking, because a lot of times they aren't.
Yeah, absolutely. And you know, in one way, you say, well, this is a heavy responsibility to place on direct care staff. And I don't know if I think what I'm trying to say about it is not so much about responsibility. I think we all have a responsibility, but it's not so much a responsibility for identifying this, but to advocate on behalf of the person to do that. And you know, this is why I keep saying that the clinical consultation network is great no matter what part of the system you work in, because ultimately, you know, if you heard this conversation today, you're going to go back and you're going to look at the folks that you have who may be over-sedated, and you're going to want to say, hey, doc, look at this situation. Check this out. This person is very sedated. We need to really try to address this problem. And I understand people may be afraid to do that in some cases because it's a tenuous balance that you're trying to address with the person's psychiatric condition. But let me also say that if a person's on 7 psychotropic medications, there are some of those that they could do without and probably do just as well. And so, giving the doctor the information so that they would make that determination, I think, is important. And, this underscores a little bit of something else, David, that you've been working on and is going to be coming out soon, called today's training on today's visit form.
Absolutely.
We're going to try to kind of give people the information that they need to be supplying to doctors when they go to see them, so that they can make sure that the person gets optimum care. So be on the lookout for that training on today's visit form that we'll be having in the near future. That could really help a lot of direct support professionals, but also administrators and other clinicians. So thank you so much, David, for this today. This has been another great case that we've had here on the Clinical Consultation Network, and we do this every Tuesday at 1:30 p.m. Central Time. We're also now getting all of these broadcasts onto the DIDD website, so there's no excuse for not getting to the Clinical Consultation Network, because you can just go there and listen to everything that we talked about. So I encourage you to go to our website and get that information, or, as is the best of all worlds, to be here in person for the Clinical Consultation Network each week. So thank you for being here, and we'll see you again next week.